for maybe 10 or 15 minutes. April Wolfson? Thoughts, observations?
I was mad because I like fell for the whole thing. I was just like, are you kidding? That was my first reaction.
I remember seeing this in the movies. The theaters.
Really?
Oh, yeah. Mm-hmm.
Wait, what year was it?
86.
86. Okay.
Yeah.
I mean, my first reaction is like the fact that Muffy went through with this April Fool's joke. Like, I wanted to know what that means about her as a person, and like, because I don't feel like your typical person would do this type of, would go so far in this April Fool's joke, and then in the end everybody's laughing and it's fine. But like, what does this really mean about her as a person? The fact that she, that this is what she finds funny.
So let's talk about that, because that also gets to what I've been trying to really impress upon everyone, and that is all behavior is normal until proven otherwise. Because at the end of this movie, we're reminded that this is all normal behavior, and there's nothing being pathologized here, or is there? Okay, so let's talk about that, because, and I'm going to ask you guys a question that is among the most difficult you're going to be dealt in your next 5 weeks, and I can tell you that a lot of my residents, especially in the beginning of the residency, had a difficult time answering. At any point in this movie, right, so I'm not going to really focus on a scene per se, in your interaction with Buffy, how did she make you feel?
There was one scene, I forget the name of the other character, but she was trying to get water and it came out all dirty, and a couple of people had already died, and Muffy's like standing there, like hands going like this, like, I think they're gonna be okay. We're gonna be okay. It was like some weird Queen voice. Just all the wrong vibes.
Yeah, it just kind of makes me feel really uneasy.
Uneasy.
Yeah.
Wrong vibes. Yeah, we're getting there. Anybody else? Sometimes we watch movies, we become immersed, right? It's the reason why we hide our eyes, we yell at the screen. Identification is a defense mechanism, right? It's when our subconscious takes over and we're just mesmerized by what's on the screen. And it is not uncommon that we feel the part of a particular character that we identify with. And in slasher films, it's usually not the perpetrator. It's usually one of the victims. Now, which one, there's factors that impact what's happening here, but identification is a strong defense. And people do experience the movie. And hopefully you do, especially if you're going to drop $50 and go out, actually watch one. Right? So, with that, I'll re-ask one more time. How'd she make you feel? Do you like her? Real tough question to ask. This question only has one answer unless you want to defy your mom and dad and what they told you. But then again, that's what we do as a factor. We have to have you unlearn all those bad habits. It's okay not to like someone.
Yeah, I didn't.
Yeah. So and all of what I'm forcing you to feel right now, full countertransference. And it's not unlike feelings that our patients conjure us. Now, when we have these feelings, we have to reassure ourselves, and psychiatry training does this, that it's okay. It's not okay to act on them, but it's okay to acknowledge them so that we can render some diagnosis and therapy and better our patient for it. It's a diagnostic tool, so don't dismiss it. Anybody here like her? So not feeling comfortable. So I might be moving off this square one, in as much as the big reveal at the end was surprise, the plot twist. And maybe this is not a one, and there's something there at all. If anything, literally the last 3 seconds maybe support this and reinforce this when the Jack in the Box winks at her. Because if she came to care for whatever reason, And in the course of her HPI, she self-reported, oh, by the way, the Jack in the Box winked at me. I'm not so sure I'd be comfortable just dismissing that as, oh, well, no, that happens. It usually doesn't happen. So there might be something going on here, and now we have to figure out what. So, where do we start? For a psychiatrist, where or what is always a good place to start. So the answer is going to be number 1 and 1B. Make a commitment. Choose whether or not you think you are observing a mood anxiety spectrum versus a psychotic dissociative spectrum. Neurophysiology, neurobiology, very similar, A and B, right? Not between A and B, but similarities, mood anxiety, similarities, psychosis dissociative. Which one do you think fits this particular case? This is an arbitrary answer, there's no wrong answer. This is just you choosing the next step toward your case formulation. So make a commitment. Psychotic dissociative. So, and again, I would probably choose the same thing, really focusing on her self-report to the Jack in the Box wink. Psychotic dissociative. All right, so for a psychotic dissociative, the next step is to choose an illness arbitrarily from which to work. So I would strongly recommend that we all agree today that any time choice B is where we're going to go, that schizophrenia is the next step. Right? So is this schizophrenia? Now for time purposes, we're going to skip over this, but when we focus on the psychotic disorders, different will be different day. I am going to want to know the inclusion criteria as well as the exclusion criteria. Right? So again, a little bit much for the time we have left in our discussion, but I do want to discuss 2 of the exclusionary criteria for schizophrenia. So, name 2, and I'll stop you when we get to the 2 that I think we need to focus our discussion on. Like major depression, schizophrenia is also a diagnosis of exclusion. And there are 5 illnesses that we have to consider, investigate, and rule out before we were to continue with schizophrenia being our most likely answer. Of those 5, I really want to focus on 2.
Medication induced?
Good. Medication is substance-induced psychotic disorder. Good. And then
Primary mood disorder with psychotic features?
that is one of the 5, but not one I care to discuss today. But it's definitely one of the 5.
Schizophrenic form?
Schizophrenic form is not one of the 5.
Delusional disorder?
Not one of the 5.
Is it like another medical condition?
That's the other one I want to discuss, right? So psychosis due to another medical condition, a substance-induced psychotic disorder, primary mood disorder with psychotic features. By the way, the other 2 are schizoaffective disorder and autism spectrum disorder. Those are the 5. The 2 that I think are, and always should be at the top of our list, are the organic etiologies. Medical conditions and substance-induced psychotic disorders. Any evidence of a medical condition in Muffy? So that hesitation means no, which means we're going to parallel this to what's important, aka the shelf exam. This means that similar to the script, not discreetly telling you, so too your clinical vignette is not telling you. When is it okay then to assume that there's nothing to be seen there? There's 2 risk factors, or if you want to flip this, 2 protective factors that should reassure you that due to an underlying medical condition is not the single best answer. Number 1 is age, and number 2 is sex. Young females are the healthiest, older males are the most unhealthy. She fits a young female. So the absence of discrete information, in this case the script, it is reasonable to assume that she does not have a medical condition that would explain her psychosis. And that's the same exact strategy you should apply to the shelf vignette. If this were an older man, 50 plus, and male, you're not going to be able to make that same determination. Substances. Is there any discrete evidence of substance use or allusion to in the script?
Yes.
Yes. So can you tell me what? Alcohol. Others?
Heroin.
Heroin. Yep. So opioids. Any others?
Weed.
The other one, maybe weed. I went back and looked at the scene again. I'm not completely sure either. I think he thinks it's weed.
It's like basil.
I'm not sure what that was, but there might have been an allusion to weed. Very big. For psychosis, of those three, two can induce what we have observed to be problematic behavior. We've identified as perhaps this patient's chief complaint, and that is the cannabis and the alcohol. There is no such thing, as per the American Psychiatric Association, as published in the latest revision of the DSM, of an opioid-induced psychotic disorder. Not the intoxication case. All right, so is April Fool's Day a case study of alcohol-induced psychosis or cannabis-induced psychosis? And be very careful, because these fictional cases, movies, I think run a very strong parallel to real life experiences. That is, if there's no discrete evidence in your patient, as a clinician, you should maintain a high clinical index of suspicion nonetheless. Because if you dismiss it, any false negative is going to harm your patient. And that is absolutely not something that you can allow to happen. Right? So we have to watch the sequel. Not sure. Not sure. You know, especially since she was intoxicated when that Jack in the Box went. Right? That's my concern. So maybe less cannabis, because we have to debate whether or not it's even cannabis. But maybe alcohol. Alcohol can induce psychosis both during its intoxication state as well as its withdrawal phase. Now she's intoxicated, so I think it's fairly straightforward. But maybe this is. Now, how can alcohol before I get to intoxication, and that'll be our final point, there's another way alcohol can induce psychosis beyond intoxication or withdrawal. What is it?
Hepatic encephalopathy.
So if I could split hairs, that's more alcohol-induced delirium.
Right.
Yeah. Yeah, so more of a Wernicke's Cortisol picture. Wernicke again would be the delirium initial acute phase, but the long effects, the chronic effects of alcohol use on thiamine can result in a psychotic syndrome called Cortisol Psychosis. And so let's start off with the acute, which again is more consistent with the delirium, which is the Wernicke's delirium or Wernicke's encephalopathy. What's the triad?
The ataxia and oculomotor disturbances.
Good. Right? And thiamine is the cause, or thiamine to treat. Right? So the acronym there is COAT. Right? Confusion, ophthalmoplegia, ataxia, thiamine. COAT. If it progresses, goes untreated, it can evolve into an irreversible neurological syndrome called Cortisol Psychosis. Cortisol Psychosis finishes out the acronym RACK, R-A-C-K. Retrograde amnesia, anterograde amnesia, confabulation, false memories to account for the amnesia, and then Cortisol Psychosis. That's exactly how we started the conversation. To finish out the acronym, Wernicke's Cortisol syndrome, then is CORAC. So again, easier to identify. I'm Michelle. Intoxication. What's the problem with this April Fool's Day being a fictional case of alcohol-induced psychotic disorder? And I think the single best answer here is, and it's only a concern, doesn't necessarily definitively rule it out, but it's alcohol by volume. I mean, champagne may not have the alcohol content or proof that would induce a psychotic episode. What are some liquors that may?
Moonshine?
So yeah. Not only homemade moonshine, but even grain alcohol. There's some other common
Was absent?
absinthe, yes. And then there's 3 others that are specific brands. I'm not going to get into the brands because we're not going to do that. But there's a rum, there's a vodka, and I believe there is a whiskey that finish out the top 5 of the highest proof. All right, any questions on April Fool's Day?
I feel like the fact that this event had to be so planned out in order for it to work makes me feel like it was less like an acute intoxication-induced psychosis, so it would either have to be like a long-term alcohol use or something else entirely.
Oh, yeah,
You know, like,
oh, yeah.
Yeah, because it's not like she just, in the moment, was like, let's have this, like, it was so planned out and
I'll
like
completely agree.
diabolical to me that,
No, yeah, if we're getting to a state where the alcohol explains how that Jack in the Box went, and we think that she's been ingesting alcohol chronically, her executive functioning would not allow her to be so premeditated. No, no way. I agree. All right, we'll end it there. Very well. So what time do we have?
yeah, totally, you know.
So, okay, so let's say at 1:15, we'll reconvene for the case conference.
What's the one
We have a presentation, right? 1:15.
115.
Did anybody eat lunch? Did anybody not eat lunch?